Good morning and welcome. I'm Laura Strickland, President and CEO of the Sylacauga Chamber of Commerce, and we're honored that you have joined us for the first of our State of series as we share the state of healthcare in the Sylacauga region. A very special thank you to Tracy Thomas and her team at B.B. Comer Memorial Library for welcoming our event to their beautiful facility. Another very special thank you to Mr. Glenn Sisk and his team at Coosa Valley Medical Center for being our partner for today's event. Access and availability to healthcare in rural and underserved areas of Alabama is an issue of vital importance to the economic viability of a community. Quality of life issues, as well as the ability to attract employers, depends on a strong community education and healthcare system. While Sylacauga-centric isn't categorized as rural, we are on the verge of rural status and are surrounded geographically by rural communities. Coosa Valley Medical Center serves as the leader of healthcare for our region and is vital to the economic growth and success of Sylacauga and the surrounding communities. Joining us this morning to share about the state of healthcare in the Sylacauga region are Glenn Sisk, Amy Price, and Dr. Don Williamson. Glenn Sisk currently serves as the President and Chief Executive Officer of Coosa Valley Medical Center in Sylacauga since October of 2001. Mr. Sisk obtained his bachelor's degree in Allied Health Administration from the University of Alabama in Birmingham and his Master of Science degree in Health and Service Administration from the University of St. Francis in Joliet, Illinois, with academic distinction. Mr. Sisk began his healthcare career with the Baptist Health System in Birmingham and was recognized as the system's Excellence in Leadership Award recipient. He also received the American College of Healthcare Executives Early Career Executives Regents Award. As well, Mr. Sisk received his Grassroots Champion Award from the American Hospital Association, along with the Distinguished Service Award presented by the Alabama Hospital Association for outstanding leadership provided to the healthcare industry. In 2022, Mr. Sisk received the Gold Medal of Excellence, the Alabama Hospital Association's highest honor in recognition of healthcare leadership and contributions both locally and statewide. Mr. Sisk has remained active in community activities, including a number of boards throughout his career, which has included the Alabama Public Health Licensure Board, Sylacauga Chamber of Commerce, Talladega County Economic Development Authority, Sylacauga Alliance of Family Enhancement, and the Earth Foundation. Mr. Sisk served as the chairman of the Alabama Hospital Association from 2009 to 2010, and for a second term as chairman in 2015-2016. He served as a member of the Alabama Certificate of Need Review Board. In 2018, Mr. Sisk was appointed by Governor Kay Ivey to the Alabama Hospital Services and Reimbursement Panel. Mr. Sisk currently serves on the board of directors for Blue Cross Blue Shield of Alabama. So at this time, I'd like to ask Mr. Sisk to come and share some information with us.
Good morning, everyone. Can you hear me okay? Do I look like Garth Brooks with my microphone? It is great to see you. Laura, first of all, thank you for the opportunity to be a part to kick this series off. We've got a lot of fantastic things happening in Sylacauga. I'd like to share with you and hope and believe that healthcare is on that short list of good things, and our intention today is to educate you not only on sort of the business of healthcare in Sylacauga. Amy Price, who serves as our Chief Nurse and Chief Operating Officer, will then share with you some clinical details that happen at CVMC every day, which I know is very, very important to everyone who is in attendance today. And then lastly, we're extremely fortunate to have Dr. Don Williamson with us today. You'll hear more about Dr. Williamson, who serves currently as the CEO of the Alabama Hospital Association and has done really incredible things in the state of Alabama through his contributions. All right, I promise you we're not going to read everything today. You have my word on that, but I do think it's important that we commit this to to a little bit of time of focus, and that is, what do we wake up every morning to do? And that is to meet people at their point of need. And this is what drives the organization. Coosa Valley Medical Center is dedicated to providing our community with comprehensive health services that enhance the health and wholeness of each individual we serve through medical and spiritual support while affirming their personal value and dignity. We also have a set of core values, and if you look with me, starting up top and down the left side here, you see an acronym called GUEST. As I said earlier, we wake up every morning to meet people at their point of need, and our guests are our highest priority. We've got a number of CVMC employees here today. I want to thank them especially for being here, and they are the face of our organization, those who meet people at the bedside each day for inpatient care, those who provide our outpatient services, the many support personnel. We'll talk about numbers in a moment. The G in guests come first. Our patients, inpatients, outpatients, family members, guests are our highest priority. We have an untiring commitment to do the right thing. We want to ensure that the organization is conducted with a firm code of integrity, and we want to be honest, sincere, and transparent as we communicate with you as our guest. We want to achieve excellence in clinical delivery. We also believe that it's not only important that we drive great outcomes clinically, we believe the manner with which we deliver that care is vitally important. Stewardship is also one of our 5 core values. We have very limited resources in healthcare. I want to talk about that for just a moment. Not necessarily when you drive through Sylacauga, but if you drive through Birmingham, what's the one thing that you guarantee to see at a hospital in the city of Birmingham? Big, huge equipment building things, right? All of a sudden, when you see things being built, people believe, wow, hospitals must be rolling in dollars. Dr. Williamson will share with you today a few details about that is not necessarily the case. So stewardship has to be a driving force in all that we do. We have limited resources, and we want to treat them appropriately. And then finally, teamwork, the last letter in our GUEST acronym. We believe in team success over individual success at CVMC. So who's your local hospital? Well, you see in the top right corner, in 1945, that incredible facility opened here in Sylacauga. Any chance anyone was here then? Some of you look like you might have been here. But is that not an incredible facility for 1945? And that hospital, just down the road from us here, held the distinction as being the only non-military hospital in the United States in 1945. Well, when they built that hospital back then, guess what? There were 0 private rooms. There were no private showers in your patient room. So a number of years ago, before we opened the West Wing, we used to get a lot of complaints. And we said, but look, you're in the only non-military hospital in the United States in 1945, and look at this sexy gown we're going to give you to walk down the hall to take your shower. That didn't go very far, as you might imagine. And fortunately, in the bottom right corner, you see the West Wing, which opened back in 2007. So the facility, known then as the Sylacauga Hospital, right? Many people still refer to it that way today, operated independently until December of 1994, at which time the Baptist Health System purchased the assets, Baptist in Birmingham. Baptist did some good things in their tenure. I will tell you, however, down the stretch, that became a little more challenging, and our ability to get the West Wing developed became apparent that wasn't going to occur. The Sylacauga Healthcare Authority, some of whom are here today, who very boldly in 2004 said, we're going to bring local decision-making back to Sylacauga, healthcare decision-making, and we believe in that. We hope to remain that way for many years to come. So the size of the hospital today, in terms of licensure, we have 148 acute care beds. We have 85 long-term care beds on the campus. You'll see that those 85 beds now are owned and operated by Prime Management, who has done a fantastic job with the 50 nursing home proper beds and then 35 beds in the rehab center on transitional care. And then our senior behavioral unit for generally patients 65 and over who face mental health challenges. And frankly, today we need to expand that service. We probably need more beds than that, and if the opportunity presents, we'll grow that. So a total of 253 beds with an average daily census, meaning on any day during the course of the year, how many patients are in beds at CVMC, and that number on average is about 130. We have 525 team members, which makes CVMC the largest employer in the city of Sylacauga proper. 15 members of our auxiliary. We have a full-time pastoral care director. And you say, well, Glenn, why don't you pick out one single job and have that on this list? And here's why. As we said in our mission statement, we believe not only that it's important that we minister, if you will, to your physical needs, your emotional needs, but we also believe that spiritual health is very important when you come to a hospital. Steve Hartzell, who is here with us today, many of you know Steve serves in that capacity. Total annual labor cost for CVMC is $36.1 million a year. Our medical staff is our franchise, so let's ask this question. By a show of hands, how many Auburn fans do we have today? 4 Eagles. And my mic falls off when I say 4 Eagles. How many Alabama fans do we have by a show of hands? Well, than usual, Alabama beats us at everything. More Alabama fans than Auburn, it appears. But I asked that question for this reason. We believe that our physicians are certainly our franchise, much like a sports team. Like on Saturdays, the 11 young men that run out on a football field are the franchise of that organization. In the fall, when Alabama or Auburn women's basketball starts, the 5 young women who run out are that franchise. We believe our physicians are much the same way. And for a community, as Laura said, that is not totally considered rural as we are in Sylacauga, we certainly are on the edge of that definition. To have this many providers is rare. 112 physicians today are credentialed to practice at CVMC, along with 47 extenders, which are nurse practitioners or physician assistants. And today we have 13 physicians who are employed by CVMC, and we anticipate that number to grow. Again, as you'll see, one of our goals has been to bring as many specialties to Sylacauga to allow you the opportunity to remain close to home for care. And for the most part, that list of specialties mirrors what you would see in Birmingham facilities. The economic impact of CVMC is very important. In many ways, Coosa Valley Medical Center serves as an economic engine for this community. Today, we generate about $45 million in total labor income each year. Today, outside of those 525 jobs that CVMC has under her roof, we create another 1,243 jobs statewide, and the total annual economic impact in Sylacauga, not statewide, the total annual economic impact in this region, Sylacauga and the surrounding region, is $132 million each year. So let's talk very quickly about some of our challenges. We'll hear more from Dr. Williamson on this on a statewide level in a moment. But the reimbursement environment is very, very poor. Something called the Medicare Wage Index drives, congratulations, the lowest Medicare reimbursement in the United States. Guess where? Coosa Valley Medical Center and other rural hospitals in the state of Alabama. Obviously a very real challenge and something that we work very closely with the association on and our elected officials in DC to try to address. We make some progress, but to illustrate for you what that means, let's imagine for a moment that CVMC bills for care and bills $1 to Medicare. And a hospital in Washington State or a hospital in Connecticut or New York bills $1. Those 3 states that I mentioned to you might get paid from Medicare about $1.85 on that dollar they bill. CVMC and Alabama rural hospitals get paid about 77 or 78 cents on that dollar. So obviously a very real challenge. Medicaid is very difficult to qualify for in the state of Alabama. Dr. Williamson can tell you far more than me in his leadership in that capacity. Medicaid, while a great program, primarily is available for expectant moms and babies in the state. Our failure to expand Medicaid has left about 350,000 or so Alabamians who go to work every day, earn too little money to buy Blue Cross or other insurance, but earn too much money to qualify for Medicaid, and find themselves in a coverage gap. So the Medicaid program, again, while important to us, and the failure to expand it, we have not maximized that opportunity. We have a very unique commercial insurance market in Alabama. As Laura said, in full transparency, I serve on the board of Blue Cross and privileged to do so. They're a fantastic company. And if I ask you to raise your hand, many of you would have Blue Cross cards in your wallets, I suspect today, as we do as CVMC team members. But Blue Cross has about 85% of the commercially insured market in the state of Alabama, which is great for them. They've done great work and deserve that result. But it does make our ability to negotiate with them on rates a little more challenging. So we do work through those challenges. And then Medicare Advantage plans are growing. Today we have more Medicare Advantage recipients than we have traditional Medicare recipients. Traditional Medicare pays hospitals more quickly. Medicare Advantage plans pay hospitals really, really slowly, which creates some challenges for us. Our emergency department, as you would expect, operates 24/7, 365. Today we have about 26 or 27,000 visits each year in the CVMC emergency department. But if you look over the last 5 years, we've not completed an audit with the 23 numbers just yet. You see that we have about $19.8 million, almost $20 million a year in uncompensated care. The vast majority of that originates in our emergency department. And what that means is this: when someone comes into the organization not feeling well, the first question we ask is not, can you show me your insurance card? The first question we ask is, what can we do to help you? And then we work through the business piece of that later. If that person unfortunately doesn't have insurance, they need to be admitted to the hospital. We admit them, they stay 3, 4, 5 days, and we never collect a penny on that care. So that's what that uncompensated care definition means. So where we are today, and like hospitals like Sylacauga across the state, I believe, and I think our board supports this belief, that a traditional reimbursement plan, commercial insurance, Medicare, Medicaid collections, is frankly not sufficient to allow us to do what we need to do. So we've got to do everything we can to find other means to support our financial health going forward. So what are our opportunities? We want to continue to grow our medical staff. Again, they're our franchise, very important to us, and we will continue to do that, and Nessa and her team do a fantastic job aiding that effort. We want to focus on growth of new strategies, new services that allow you, again, if today we don't have a service in Sylacauga, we want to bring that service on a couple of questions that need to be answered. We'll talk about that in just a moment. When the pandemic hit, Dr. Williamson and I and many others had a lot of sleepless nights, as you might imagine, especially him leading the efforts of our hospital statewide. But we did everything we could, direct credit to our finance team, for pursuing every penny available in pandemic funding. And that was super helpful. Frankly, it kept the doors of hospitals across this country open. But those dollars are gone, so we don't have that privilege anymore. I know we have a number of elected officials here with us today. We believe that local government support is very important. To that end, especially want to thank the leadership of the city. Last year, they purchased the telemetry system. If you come in and need to be monitored at CVMC, we have a brand new telemetry system that the city supported us, and we're very thankful for that. However, as we've said to the city, we need long-term support, something that's committed year after year. Today, there are 42 healthcare authority structured health systems in Alabama, 31 of which receive support through some level of tax, and we're working with the city and hopefully we'll be able to get there. We want to increase philanthropic giving. We do have a foundation. Rosa Butts, Rosa, let everybody see you. She'll be asking you when we pass the plate in a moment. We're thrilled to have Rosa with us. What I would tell you is this: our foundation is doing great work under Rosa's leadership, but it's not on par with a couple of foundations in this community that we believe in and want to support. I see Dr. Shirley Spears in the back. Let's give her just very quickly a quick round of applause for this facility. How impressive. Shirley did a fantastic job with her foundation, continues to do that, and of course Tracy, I don't know if Tracy's with us this morning or not, but the leadership they have provided is stellar, and as I've heard Dr. Shirley say a number of times, a $25 gift is as important as a $25,000 gift if it continues. So we appreciate her support of our foundation as well. And as I said a moment ago, we want to drive clinical outcomes that are on par with all competitors. Amy's going to walk you through in just a moment some details about how we're performing in that regard. If we decide that we want to bring a new service to CVMC, we ask ourselves two questions. First question is this: can we deliver clinical outcomes that are on par with all hospitals in this region? There are two hospitals geographically closest to us, as you know who those are, Citizens Baptist and Talladega Russell, down in Alex City. But the out-migration from our community, as you know, for the most part goes up to 80 to Birmingham. So we compare ourselves with those facilities. And if the answer is yes, we can deliver the same clinical quality that is on par with those facilities, then we move forward. The second question is this: can we do so in a fiscally responsible manner? Remember, part of our core values, stewardship, very important. It's hard to have services that can't be financially responsible. So we ask ourselves those two questions, and Amy will walk you through some of those results in just a moment. A few future strategies that are sort of close or on the cusp of making happen. We have for a number of years wanted to bring plastic surgery and cosmetics to Sylacauga. I'm pleased to report to you that in February, we will be doing just that. We had a couple of plastic surgeons come to the community. Many of you will know Dr. Juan Campos. Everyone probably knows Dr. Campos. He's cut on me before, and maybe has cut on you before as well. Dr. Campos has been away for a couple of years doing a plastic surgery fellowship, and we're excited to have him back in February. He brought one of the guys that's training him recently to the campus to do a Botox clinic. So I went by to say hello. I hadn't seen Dr. Campos in quite a while, to meet the gentleman who was leading the fellowship. And, there were a number of folks in the clinic. I was the only man in the clinic. He was starting to get in my vibe. Came in and introduced myself, and I noticed that he was looking at my face. And I'm thinking, surely he doesn't think. And he keeps looking at my face. And I said, well, it's great to see you. He said, sits me down, gets the needle out. And I said, doctor, I'm not here for Botox today. I'm just here to say hello. 42 sticks later, I got Botox. So I highly recommend it. I'm not sure I'm beautiful yet, but we're trying to work on it. We need to bring full-time urology service to Sylacauga. Certainly thankful for Dr. Pasha and the work that he's done for 40 plus years. We need full-time urology service. Likely not in position to do that just yet, without the addition of some equipment that is going to be very important to us, and we're having some conversations about that. That is a huge priority. Actually, we have just started Venus Hill service. Amy and Jeremy are leading that effort for us. It is primarily focused on lower extremity care, varicose veins, etc., related problems, and we're very excited about that. And again, a service that will allow people to remain in Sylacauga. And then finally, we have been training 3rd and 4th year medical students for 10 or 12 years, I suspect, Lindsay. Vanessa and Lindsay lead that effort for us, and we will continue to train 3rd and 4th year medical students. However, when they finish their 4th year with us, they are required to go away, to leave the community, to go to bigger cities in order to accomplish their residency program, residency training. So we're having conversations now about the prospects, and feel reasonably confident that not only soon we'll be training 3rd and 4th year medical students in Sylacauga, but also we hope to be having a residency program in primary care that will then aid the growth of primary care as we go forward. So with that, I thank you for your time. We've got 2 folks who are going to be following me. Laura, you're going to make some introductions. As you were talking a moment ago, I thought to myself, well, Dr. Williamson and Amy and Glenn have figured out one thing. There are 2 times in life when we're perfect. One is when God breathes life into us, right? And 2 is when we write our Bible. Yeah.
Thank you, Glenn. Our community is so honored to have Glenn at in the leadership role for Coosa Valley Medical Center. But one of the other amazing items that he has brought to the table is putting together a tremendous leadership team. And I think that contributes to the success of healthcare in our region. So thank you, Glenn, for being a part of that and for assembling such a rock star team. Many of those you'll see here today. But I'm excited next to welcome Amy Price. Ms. Price joined Coosa Valley Medical Center in September of 2002. She is the Chief Operating Officer and Chief Nursing Officer for CVMC. Mrs. Price is responsible for the clinical delivery and patient care activities on the CVMC campus. Prior to joining CVMC, she worked for Fayette Medical Center in Fayette, Alabama. Governor Riley appointed Mrs. Price to the Alabama Board of Nursing in 2009 for a 4-year term, and Governor Bentley reappointed her in 2012 for a second term ending in 2016. During calendar year 2012, Mrs. Price served as the board president. In 2016, Mrs. Price was appointed by Governor Ivey to the Alabama Commission on Higher Education for a 9-year term representing health science programs. She currently serves as vice chair for ACHE. Mrs. Price also serves as a current member of the B.B. Comer Library Board and a member of the Sylacauga City Schools Board of Education. Mrs. Price was recently nominated by Alabama Health Occupation Students of America, HOSA, and received the National 2023 Caduceus Award, recognizing her creating partnerships and strengthening the pipeline for healthcare workforce. During 2016, Mrs. Price was honored by the Sylacauga Beautification Council as the Nanellen Lane Citizen of the Year. Mrs. Price holds a Master of Science in Nursing degree from the University of Alabama in Tuscaloosa. Amy and her husband Dale live in Alpine and have 2 daughters, Lily Francis, age 18, and Catherine, age 16. So please help me welcome Amy Price.
Good morning, can y'all hear me okay? All right, I'm glad I don't have to find an earpiece. So following Glenn is really hard to do, right? I mean, you think you gotta get up and talk to folks in the morning, and then you gotta follow him. It's a pretty tall order. But when I heard Laura make her opening comments, I'm thinking, wait a minute, I'm raising 2 teenagers and I'm surviving that at least by 10:30 this morning I am. So maybe I'll get through the next few slides. What I want to share with you this morning is not really exciting per se for a group like this to hear, but I think it's important for you guys to hear, because one of the things that we talk about a lot on our campus is finding ways for you to feel confident about the health care that you can get close to home. We don't want you to run up the road or down the road to find the health care that you and your family need. We want you to have confidence in choosing us and make a conscious decision to be on our campus, not just be here because we're close to home. So we really worked hard, and when I say we, that's 500 people strong, and we're going to talk about that in a few minutes, but we've really worked hard to brand our care, and that starts with our medical staff. So Glenn mentioned our physicians, and they really lead the effort for us in all things clinical. And then a lot of people think about healthcare, you think about nursing. Obviously, nursing is a huge piece of that. But in 2023, healthcare is much more than nursing, it's much more than physicians. It's respiratory therapy, it's lab, it's radiology, it's all kinds of specialties, pharmacy. There are many, many more I could name. But it really takes a full interdisciplinary team, and I know Dr. Williamson can appreciate that approach, but that's the only way to really move the needle in healthcare today. So y'all bear with me as I show you what might look like a few boring graphs to you. I want you to know that we're really proud of what we're going to show you guys, because it shows you, hopefully, that we're paying attention to evidence-based medicine, and we want you to know when you see these results, it's the kind of health care that you can get close to home and be confident that it's the right care. So Glenn won't allow me to mention the hospitals that we are comparing ourselves to. I'm pretty sure he said, hey, I really don't want you to get into naming all those hospitals. So this is the way I'm going to get around that. We compare ourselves, obviously, from a geographic perspective to the choices that you all have to go get health care. So that includes hospitals, in my mind, in Talladega County, hospitals in Tallapoosa County, and hospitals in Jefferson and Shelby County. So you'll see represented on several of these slides at hospital A, B, and C, but you can use your imagination about those 3 counties and what they might represent. And Dr. Williamson, we know you're a Coosa Valley fan today. So, all right. Very timely that Laura asked the hospital to speak today. This happens to be the end of Sepsis Awareness Month, and sepsis is a huge initiative for Coosa Valley Medical Center. And you might be saying to yourself, what is sepsis? Well, sepsis is really what happens in your body when infection goes untreated, or when infection goes untreated or is not treated with the right antibiotics in the absence of maybe cultures. So sepsis is a huge initiative not only here in Alabama, but CMS is requiring hospitals to work on sepsis. And we were a little bit slow getting started on sepsis. We didn't really make as much progress as we wanted to over the last 3 years, but the last 12 months, we have done some exceptional work. Jeremy Herring, Tanya Henderson, Victoria Singleton, many of our sepsis team members are here today. I see Jeff, I see Heather back there. And these guys have put together an amazing team and really moved the needle for us. So when you look at how we compare from a sepsis compliance perspective, you might be looking at the slide thinking, well, that looks pretty good. I mean, obviously, we're outperforming the nation, we're outperforming Alabama, and several of those close hospitals I alluded to. One of the things that this bundle, if you will, looks at is how quickly do you get care when you show up in the emergency department. And every diagnosis that I show you this morning is going to be focused around how quick is your access to care. If you don't get to us, there's not a lot we can do about it. But when you get to us, we have a responsibility to act quickly. And that's what's important when we talk about diagnoses like sepsis. So the sepsis bundle includes things like making sure we get blood cultures. We need to know what's growing inside of you so physicians can adequately treat it. Not only does it include blood cultures, it includes getting a lactic acid, it includes looking at how your body uses oxygen, and it includes starting antibiotics timely. And so these are really important initiatives to help you have a good outcome and be able to survive sepsis, is to get timely care. And guys, our team has moved the needle. I'm not going to tell you how low we were, but we did meet our goal of 75% initially and now have exceeded that and are going to continue to improve. And in fact, several weeks ago, Heather was contacted by Blue Cross to say, hey, we want to know more about what you guys are doing for sepsis because it's pretty impressive work. So we're very proud of this work and want to, it's one thing when you look at making improvements to reach your goal, but the real hard work comes in sustaining your goal. So if we can come back in front of you guys in a year or 2 years from now and say, look, not only are we still at 88, but we've improved to 90, that's when we'll know the good work is continuing. So we're very proud of our work on sepsis. Another indicator that CMS looks at is pneumonia readmissions. You have to remember when Medicare or CMS looks at a hospital, they look for ways not to pay us. That is their incentive. How can we ensure they get patients treated, but make sure we don't spend too much money paying them for the drugs, the labor, the linen, all the things that it takes to take care of a patient. So they look for ways not to pay hospitals. And one of the ways they do that is they say, look, when you have patients leave your hospital, if they come back too quickly within 30 days of admission, then we're not going to pay you the full 100% rate for that diagnosis. We're only going to pay you 70% of that rate or some lower number because they're holding hospitals responsible for being readmitted. Now, how does that make sense, right? Doctors don't work for hospitals. Some do, most don't. And hospitals don't prescribe medication. Our providers do. But that's how the system works. And I know we could spend the rest of the day talking about how broken the reimbursement system is. But this is one of the factors that we're held accountable to. And as you can see, we're performing very well. You want this number to be low. So this is one of the areas that you want it to be lower rather than higher. We're performing very well, comparatively speaking, on a national, state level, and then looking at hospitals that are close to us. We want to continue to drive that number down, and it does fluctuate. All of the numbers I'm showing you today are publicly reported. You could go out on Hospital Compare, CMS Compare, and look at all these numbers for yourself. But from a pneumonia perspective, our team has developed order sets. Our physicians, again, drive prescribing patterns for those order sets. And pneumonia care is about getting care timely and making sure that when you're discharged, you have appropriate resources at home, whether that's a follow-up visit with your doctor, home care, the support that you need not to have to come back to the hospital to be readmitted. You heard me earlier allude to evidence-based practice or evidence-based medicine. And when physicians are looking at how to treat patients, when I first graduated from nursing school, I'm not going to tell you how long ago that was, but it was a long time ago, doctors really made the decision themselves for how to treat patients. And over time, we've evolved into what's called evidence-based practice. And so now CMS, American Heart Association, other organizations really produce standards on how they want doctors to treat patients. And I've heard physicians like, I'm going to pick on Dr. Pinson for a minute, I've heard physicians like Dr. Pinson say, I'm not using cookbook medicine. They're trying to tell me how to practice. When now physicians come out of medical school and they have been taught how to practice using evidence-based medicine. So the reason I'm sharing this with you today is there are 3 diagnoses that we work really hard on to follow from an American heart perspective, and that's stroke, STEMIs, and heart attacks, MIs, which are not up here. But we're doing lots of work in our building trying to improve the timeliness and access of care for these diagnoses. You guys know that when we're talking about a heart attack, when we're talking about a STEMI, or when we're talking about a stroke, again, it's important to get fast care. It's important to get access to care quickly. From a stroke perspective, I think it was Monday of this week, I said to Jeremy, have we had our CT scanner 2 years yet? He's like, yes ma'am, it'll be 3 years. So time's getting away from me on the CT scanner, but we added a second scanner, be 3 years ago, I believe in October. And guys, that second scanner has made a huge difference in your access to care. So when you think about coming into the emergency department, we had a STEMI come in Monday, and that patient was rushed right to CT. Well, historically, what that meant for us is that if you were in the ER with something else, you were waiting on the CT because we had a patient in the scanner. Having 2 CT scanners on our campus has made a huge improvement in access to care, and this slide is a perfect example of that. So now if you come in with stroke symptoms, we're able to even get you a CT more quickly than before because we now have 2 scanners on campus, and as you can see, we're really doing well. Over almost 100% of the time getting patients a CT within 45 minutes when they come in with stroke symptoms. Time is muscle, they say. Time is brain. It's very important to get timely care. This slide is one of those not so exciting slides, but when we talk about GI upset or GI problems, a very common problem for hospitals and infectious disease is overutilization and utilization of antibiotics. And for patients who are age 65 and older, there's a very high risk of getting C. difficile or Clostridium difficile as we know it. And oftentimes, hospitals are penalized for patients getting C. diff as a nosocomial infection, meaning that the hospital is being held accountable for you picking up that infection while you're on our campus. So Jeff Wood serves as our infection prevention nurse, and our ICU team, Angela and Kristen, have done some tremendous work along with our second floor staff on making sure that we do everything we can to drive down our nosocomial infection rates, because we want you to be able to come to our campus and get care, get the antibiotics you need, and not leave with an additional infection that you may have picked up on our campus. So this slide may not be very exciting to you, but it's something we're extremely proud of, because there could have been a time several years back where we stood in front of you and said, look, we got work to do on this. This is one of those areas we've got to improve upon. So we made great improvement here, and to date have had multiple years now without any C. diff cases that are considered nosocomial. So proud of that work. Hospital star ratings. I'm going to try not to let the next few minutes digress into complaining about Medicare and star ratings, right, Dr. Williamson? So Medicare started many years ago rating hospitals based on star ratings. And over the last few years, we've struggled ourselves with being a 3-star hospital, being a 4-star hospital, wanting to be a 5-star hospital. Glad we're not a 2-star or 1-star hospital. And just recently, Medicare had an update in the last 45 days or so, and we did move from a 4-star facility to a 3-star facility. One of the first things that we do when we look around at ourselves and say, why is it that we decreased? We do a deep dive and we look at reasons why we decreased. And some of those reasons can be some of the indicators that I showed you. They can be patient experience. There's a multitude of reasons, very complicated calculation that go into this star rating. But over the last 45 days, there's been a lot of hospitals very upset because this new star rating that was published has had a lot of hospitals fall. In fact, I have not run across a hospital yet that improved with the last update, and usually the update is annual. So I wanted to show you guys our star rating. Again, this is available in Hospital Compare, and it shows you all the indicators that are used to calculate the star rating. And we are currently a 3-star rating. And then when you look at the company that we keep or the company that we're in, you see there how other hospitals close to us compare on their 2-star rating, whether it's 2-star or 3-star rating. So just wanted to share that with you because that's an overall summary of these characteristics or graphs that I've shown you this morning that are diagnosis specific coupled with the patient experience rating. So we're 3-star today, hope to be back in a year from now on the 4-star list, but glad not to be alone on the 3-star list. So. And then this is COPD readmissions. Again, it's just like pneumonia readmissions. The lower, the better. We've done some great work. Not anything up here has happened by accident. What I'm showing you this morning has been very targeted work by our clinical team. One of the things I hear most about from the community, or get called most about, is ER. People call and say, hey, Amy, I'm bringing my mom to the ER. Is there a long wait? Hey, Amy, my dad's been in the ER. He's been waiting 30 minutes. He's got chest pain symptoms. Can you guys get him out of the waiting room? And we want you to continue to call us. We want you to call us because we want to be accessible to you because it's your hospital. So one of the other initiatives that they measure us on nationally is how long do patients stay in your emergency room? And guys, we're super proud of this number. Our emergency department is led by Dr. Sunny. She's our medical director, many other physicians that work with her to provide care down there. They also work with our medical staff, many of the family practice physicians that are in our community and others that you guys know and use. They work with those physicians to get patients admitted to the hospital. But we're super proud of this 111 minutes. It's 111 minutes longer than what you probably want it to be, but it's a lot better than it has been. We've been up over the 2-hour mark before, over 120 minutes. And again, it's one of the things that Vanessa and her team look at when they find ways to go out and tell people about the quality health care that you can get close to home. Look how quickly you can get in and out of our ER compared to those surrounding hospitals. So again, I'm very proud of that work. And then the last thing I wanted to say is I've shown you a lot of numbers, a lot of graphs, and probably some boring statistics. But these are the people that make those things happen. And Glenn mentioned we're 500 people strong, and there are many of them here today, but there are many of them back in our building making things happen for patients today. And they'll be there tonight, and they'll be there at 2 o'clock this morning when we're in bed. So thank you guys for listening to us talk a little bit about our quality work, but a special thank you to our CVMC clinical team and our physicians for helping us make all the improvements that we were able to share with you. Thank you.
If you don't leave here this morning convinced about the quality of health care you'll receive here at CVMC, then you haven't listened. I can't tell you I'm just so proud to be able to boast to others in the state and beyond about the quality of health care that we have and the partnerships with Coosa Valley Medical Center. At this time, I would like to welcome Dr. Donald E. Williamson to share with you. He has served as the president and CEO of the Alabama Hospital Association since November of 2015. Prior to joining the Alabama Hospital Association, he worked in the Alabama Department of Public Health for 29 years, serving as state health officer and director of the department for the last 23 years. In addition, during the last 3 years of his service, he had the opportunity to assist in efforts to transform Medicaid. Dr. Williamson was recognized by his peers with several awards, including the Nathan Davis Award for the American Medical Association, the Child Health Advocate Award from the American Academy of Pediatrics, and the Paul W. Burleson Award from the Medical Association of the State of Alabama. In 2016, Dr. Williamson was selected for the Alabama Healthcare Hall of Fame. Dr. Williamson received his MD degree from the University of Mississippi School of Medicine and completed training in internal medicine at the University of Virginia. Dr. Williamson, welcome to Sylacauga, and thank you for being here.
Well, thank you so much for the opportunity to be here. I made a decision not to use slides because I wanted to make this more conversation. What I wanted to talk to you about is a healthcare system that's about to collapse. Now, you are in a unique position in Sylacauga. What I'm going to talk about largely doesn't relate to the financial challenges of Sylacauga and Coosa Valley. But number one, as a nation, we have a healthcare system we cannot afford. That's the first and unfortunate reality. We provide world-class health services, except for the 10% of our population that's uninsured. So when I start talking about Alabama, which is what I'm going to focus on, I want to start by putting in perspective how bad things are. There are 90 acute care hospitals in Alabama. 52 of them are rural. Of those 52 that are rural, 65% last year lost money on operations. Of those, 29 or 56% are at risk of closure. The definition of being at risk of closure is in the last year they lost money on operations and they only have reserves that will keep them open for another 5 to 7 years. Of those rural hospitals, 19 or 37% are at immediate risk of closure. Immediate risk of closure means they've lost money over the last 2 to 3 years and they only have enough cash on hand to survive between 1 and 3 years. So we are in a situation where, and unfortunately I can tell you from our own experience, both when I was health officer and the privilege of the last almost 10 years, those numbers are probably right. So we're in a situation where unless something changes, we're going to see a fundamental change in the healthcare system in Alabama. Now, the question is, when I say a hospital is going to close, the response I often get from the media is, well, Don, nobody's closed recently. You're right. The last hospital to close in Alabama was in Pickens County, and it was in, I believe, March of 2020. Anybody remember what happened in April of 2020? We had our first COVID case. So hospitals are very, very creative. They will find ways to stay open because their mission is to serve the citizens, to serve the community. They're in most counties, they are the school system or the largest employer. In many cases, they're the only healthcare provider for miles, 20, 30 miles. So what we see happen is we'll see hospitals give up lines of service. They may close their delivery service because they're not delivering enough babies. We're seeing that now. We see 2 hospitals in the Birmingham area close delivery to consolidate. They may, if they're not part of a system, they may start looking for a partner, a larger system that they can merge with to absorb some of their debt, to provide some fiscal resources so they can do the construction, so they can buy that second CT unit that the hospital needs. Rural hospitals have the opportunity to convert to something called a critical access hospital, which limits how long somebody can be in the hospital, or maybe even become a new designation called a rural emergency hospital, which means they give up their beds and basically only become a freestanding emergency department with some outpatient services. And as a last resort, we have hospitals in Alabama right now that are borrowing money in order to make payroll, to buy drugs to take care of patients in the hospital. So they're hanging on by a thread. The question is, why? Well, you're going to have heard Glenn allude to some of these, but there really are 2 major drivers that are creating the crisis for Alabama hospitals. One is financial, one is workforce. And under financial, there are really a couple of things. One is the impact of COVID. And the second is our payer mix. So I want to talk a little bit about those. I want to talk a little bit about the impact of COVID. We did a study at the end of last year and reported it early this year looking at the impact of COVID on Alabama hospitals. And we compared 2019 as the base year to 2021, 2022, 2020, 2021, and 2022. The study was done by a firm called Kaufman Hall. Kaufman Hall does this nationwide for hospitals. So we got them to do it specifically for Alabama hospitals. And what we found is that in 2022, Alabama hospitals had a 79% decline in operating margin. Nationally, it was about a 25% decline. So Alabama hospitals did 3 times as bad relative to operating margins as the national average in 2020. And just so everybody understands, that includes all federal money. When you break that down even a little, and the other thing that led to, not surprisingly, is in Alabama in 2022, 50% of all our hospitals were now having negative operating margins, including your urban hospitals. Let me put that into numbers. They're too large for me to understand, but they're at least numbers. In 2022, Alabama hospitals had $738 million less coming in than they did in 2019 in operating margin. If you look over the 3 years of the COVID pandemic, Alabama hospitals lost $1.5 billion. Had it not been for the federal dollars, that number would have been $2.4 billion. Those are numbers that you really can't fix that. Those are intrinsic dollars where we've got hospitals that may have built up reserves for a decade. Many of those hospitals have spent those reserves. They're now looking for how do they partner, how do they survive. Well, the other problem is not only did operating margins went down, they went down for a couple of, well, really for one big reason. Cost went up. Total expenses went up by $2.6 billion just in 2022 compared to 2019. And in addition to that, the patients that Alabama hospitals are seeing now are sicker and their length of stay is longer. Now, why is that? Well, the length of stay is longer for a couple of reasons. Number one, it's longer because patients that are coming now are more ill. But it's also longer because of the workforce shortage. If you cannot move a patient out of the hospital to another post-acute care setting, nursing home, rehab facility, because they have a workforce shortage, they end up staying in your hospital, which might be fine if the third-party payer paid for that extended length of stay. But Medicare pays a fixed amount. So if your length of stay goes up, your cost goes up, but your reimbursement does not correspondingly go up. All of which make the problem worse. So the bottom line, in 2022, revenue went up by $1.8 billion, cost went up by $2.6 billion, hence hospitals lost $738 million. If we look at the 3 years of the COVID pandemic, expenses went up by $4.6 billion. Revenue went up by $3.2 billion, hence the net loss was about $1.5 billion during the 3 years of the pandemic. Those are dollars that includes the federal support they got. It simply means those are dollars that are now lost to operations. Those dollars are not there to help buy a new CT scanner. They're not there to recruit and retain new physicians. They're lost to the healthcare system. Now, we're going to talk a little bit about, when we talk about workforce, what I think may be the most significant component of that. But just understand, the cost is a huge challenge. For 2023, some things are going to get better. The pandemic, fortunately, I mean, just so everybody knows, we're never going to be done with COVID. COVID is now going to be like influenza. It's endemic. Anytime people get together in large numbers indoors, you may see spikes in COVID, you may see increases in hospitalization, but unless we get a mutation in the virus in a way that makes it more deadly, it's simply going to be, for most people, an annoyance, not the kind of disaster that we saw in 2019 and in early 2020. If you haven't been vaccinated, please get vaccinated. Stay out of the hospital. So that's a positive. Expenses in 2023 are probably going to have mitigated a little, especially on the workforce. But at the end of the day, there are some built-in things in 2023 that are unlikely to allow us to return to pre-pandemic levels. And three large rating agencies, Moody's, S&P Global, and Fitch Ratings, basically have said that the outlook for the healthcare industry in the United States in 2023 is uncertain, that operating cash flow will grow, but margins will continue to be suppressed. Labor expenses will still be the single biggest driver, and that the credit gap will continue to widen. Now, why that becomes important is if a hospital can't access cash for construction, hospitals, Glenn talked about if you drive through Birmingham, you see construction cranes in hospitals. That doesn't mean the hospital is financially doing well. It simply means they are having to make construction, they're having to buy equipment in order to stay where they are. And if you can't stay where you are, you're going to fall backwards and you're going to get a tight downward spiral toward closure. So now I want to move to the second issue, and that's the payer mix. In Alabama, we have the worst payer mix in America for a couple of reasons. Glenn's already alluded to the fact that Medicare is not a great payer. Well, in Alabama, 16.2% of our population is on Medicare. The national average is only 14.3%. So we have an older population with a higher percentage on Medicare. Secondly, we have a lower percentage on Medicaid, 21% nationally versus 19% in Alabama. Why is that a problem? That's a problem because we haven't expanded Medicaid. We're going to talk about that. And then last but not least, the one that's the biggest problem is tied to the failure to expand Medicaid is the uninsured population. In Alabama, the uninsured population accounts for 10% of our population. Nationally, it's 8.6%. That uninsured is not distributed equally, and we'll talk substantially more about that. Let me talk about Medicare for a minute. There are two problems with Medicare. One is the wage index, the area wage index, the AWI that Glenn alluded to, and the Medicare Advantage plans that he's already talked about. Medicare Advantage plans were not an issue until both the state employees and the teachers both put their retired employees in the Medicare Advantage plans. Medicare Advantage plans are more difficult to get paid by. They tend to do retroactive audits, disapprove payments that they've already previously approved. Prior authorizations become more difficult. That's an issue. That's a challenge. Wage index is a national issue. We can't fix that one in Alabama. But the way the wage index works, there's a fixed pool of money. If we pay a California hospital, let me use Glenn's example, $1.85 for something, and we only pay an Alabama hospital 85 cents, what's the difference? Well, the difference is the California hospital now has a whole dollar more. What do? They can pay their nurses, their janitors, their radiation techs more. Their wage index goes up again. All right, when their wage index goes up again, what happens to Alabama's wage index? It goes down because no new money is pumped into the system. It's a closed loop. And so the wage index is one of the drivers for rural hospital failure. Unfortunately, the only way to fix that is at the federal level. The only way to fix that is with new money, because you're never going to convince California, Oregon, Washington, Connecticut to give up money to come to Alabama. That's never going to happen. And politically, we don't have the clout to make it happen. Medicaid, and I had the privilege of working with Medicaid for 3 years. As a Protestant, I never believed in purgatory, and I'm rethinking that considerably. The challenge is most people think of Medicaid as a program for poor people. That's not what Medicaid is. Medicaid is care for pregnant women, for children, and it's welfare for the middle class. And I say it's welfare for the middle class because 70% of people in nursing homes are on Medicaid. So through spin down, we want this entirely different talk. You can get most of the people who end up in nursing homes on Medicaid. Medicaid does not cover childless adults, 19 to 64 years of age. It doesn't matter how poor you are. The only way a 25-year-old individual can get on Medicaid is one of two ways. Either they get pregnant, if they're female, or they become disabled. It doesn't matter that they don't make any money. It doesn't matter that they may lose a kidney from diabetes or that their vision is deteriorating. It simply doesn't matter. We don't cover those people. Now, if you're the parent of a child who's on Medicaid, and it's just a two-parent household, as long as you don't make more than $3,600 a year, not a month, $3,600 a year, you can qualify for Medicaid. If you're a family of four, as long as you don't make more than $5,400 a year as the parent, you can qualify. I don't know about you, but I can't pay my bills on $5,400 a month, much less $5,400 a year. So, as Glenn said, these are all working people who can't qualify for Medicaid. The other problem with Medicaid is we're in the only state in America where Medicaid is nothing more than a contract. It's a contract between the federal government and the state of Alabama, in which the federal government says, look, if state, you will provide these services and put up this amount of money, we will give you this amount of money. And that's based on the relative income of Alabama versus other states. And for us, it's about 28%. You know, we put up 28% of the money, the feds put up 72% of the money, and we're all happy. Alabama is the only state in the country where 100% of the money that's paid to hospitals, the hospitals put up the state share to pull down that money. So instead of the state of Alabama putting up $700 million a year or $650 million a year to pull down the money to pay the hospitals put up the $650 to $700 million through something called intergovernmental transfers and taxes. So what does that mean? That means if something costs me $100, even if I'm never going to get that cost back. If they give me $100 for Medicaid, well, $28 of that I've already put up as a state share. So I'm going to lose money on Medicaid. Now, don't get me wrong. Losing money on Medicaid is better than 72 cents on a dollar is better than 0 on a dollar for the uninsured. So that's the challenge with Medicaid. Glenn commented that we have a single payer in the state. Well, the reason that's important is if you look at, there's a study done, this was from 2021, and it compares what commercial payers pay relative to what Medicare pays. On the inpatient side, nationwide, commercial payers pay about 190% of what Medicare pays. On the outpatient side, they pay 264% of what Medicare pays. Now, in Alabama, congratulations, we have the third lowest outpatient ratio in the country. We get only 175% of what Medicare pays. If that weren't bad enough, remember, our Medicare reimbursement is the lowest in the country. So we're getting 175% of the lowest number in the country. So that makes it even worse. We come fairly close to the national average on inpatient, but the problem is all the trend for healthcare is toward outpatient. So the fact that we are getting squeezed on the outpatient side by commercial insurers makes the problem worse. Lastly, there was a study done, this was from 2022. There are the 10 top states for consolidated insurance markets. Delaware, Vermont, I'm going from 10 forward. Delaware, Vermont, Illinois, Alaska, Kentucky, South Carolina, Hawaii, Louisiana, Michigan, and Alabama's number 1 in something other than football. We have the most consolidated insurance market in America. One insurance, and that's not a bad thing. I've got a Blue Cross card in my pocket. But what it does is it limits your ability to negotiate for prices. All right, now let me talk about the uninsured. I said that we have 10% uninsured, the nation has 8.6% uninsured. Well, the truth is, if you look at 0 to 18-year-olds, Alabama's done a remarkable job. When I was health officer, at one point we had 15% of the children who were uninsured. And we had the privilege of having the first child health insurance program in America approved. And we got our uninsurance rate down to 3%. Today, our uninsurance rate for children is 4%. The national rate's 5%. So we do better than the nation for children. That's why our rate is no worse overall. If you look at our rate of uninsurance for 19 to 64-year-olds, these are the people who don't qualify for Medicare, but these are the people who could be covered if we close the coverage gap. Our uninsurance rate for 19 to 64-year-olds is 14.9%, about 15%. That means 1 out of every 7 people to 1 out of every 6 people on average who come to the ED are uninsured. If you ask some of Glenn's colleagues, they'll tell you it's 1 out of 4 in some of our rural counties. I'm sorry. You cannot run a hotel if you're giving free rooms to 1 out of 5 people who come to your hotel. And you've got to feed them. And under federal law, you have to provide them health care. It's not sustainable. For workforce, when we looked at the cost, the major driver for healthcare costs during the pandemic was workforce. Workforce costs in Alabama in 2022 was $1.4 billion more than it was in 2019. All that $1.4 billion, most people would say, well, it's all those high-priced contract nurses you brought in. And yes, $300 million of it was contract nurses. But $1.1 billion was paying higher wages, bonuses, and things to keep and retain your existing staff. The problem that creates is that's built in. You can do something about contract staff. And we've seen that happen. Salaries have gone down for contract staff, lower utilization of contract staff. But you can't roll back the salary of a nurse who works in your hospital. Not if you want to keep that staff. So that's a built-in cost that Glenn and every other hospital around the state now have to deal with. And guess what? Reimbursement has not kept up with that cost, of that increased staff cost. So we took a look at, earlier this year, we did a survey of staffing shortages. Well, now, this won't surprise you maybe, but there's a 21% shortage in Alabama hospitals of registered nurses. There's a 16% shortage of CRNAs, people to put you to sleep and more importantly wake you up. There's a 13% shortage of phlebotomists, just people who go around and draw blood. A 19% shortage of people who push gurneys, who push people to procedures, to x-rays. So if you don't have a transporter to move somebody, who does it? Somebody else, a nurse, an LPN, taking them away from the service that they would normally be providing. 18% shortage of people working in dietary. And I've got stories of hospital CEOs during the worst of the pandemic delivering meals themselves because there was literally nobody else to do it. People to clean the room, there's a 25% shortage of people available to clean rooms. Now the good news is there is active work going on to address that. Working with 2-year schools, we now have more than 400 people. Hospitals are doing this. They're trying to solve their own problem. 400 people working in nurse apprentice programs, getting the training that then they can take, and when they get degreed, use it. We've got a $31 million grant that is not even out there yet for hospitals to work with two-year schools on rural healthcare opportunities. We've now got a hospital that's opened its own nursing school, just got approval to open its own nursing school. There's going to be a $10 million grant called the Birmingham Good Jobs Challenge for counties around Jefferson County to partner with universities and two-year schools to provide more opportunities for training. So workforce will get solved, it's just not going to be solved quickly. The financial situation is more challenging. If you look at fixing the financial situation, I mean, yes, we'll continue to scream about AWI because we have to. But I'm not naive enough to believe that suddenly Senator Feinstein in California or former Speaker Pelosi, who lives near the hospital with the highest wage index in America, is going to suddenly say, if you're right, Don, a wage index of 1 is fine for California. We're going to raise you from 0.75, pick a number, to 1. No, we're not going to move that fight. We have to find a way to get either a new model other than the wage index or a way to put new money into that program so that we create a floor for everybody, so nobody goes below 1. The choice we have that will make the biggest short-term difference is closing the coverage gap. Now, let me be clear. I'm not advocating. I see Medicaid in all of its positives and negatives. I'm not advocating a traditional Medicaid expansion because that's just not going to happen. But we demonstrated using the Child Health Insurance Program and a partnership, and a public-private partnership between Medicaid and the private market Blue Cross, that you could construct a program that was efficient and wildly popular and wildly successful. And I think there's that same opportunity for us to look at in closing the coverage gap. It's a different model. It's not a traditional expansion, but it would provide coverage for hardworking Alabamians who are right now left in the gap. There are over 200,000 people, 250 to 300,000 people who literally make too much money or who are in a category that can never qualify for Medicaid, but make too little money, 100% of the poverty level, to qualify for a product on the exchange. How do we do that? Well, number one, if we close the coverage gap for the existing Medicaid population, the federal government for the first 2 years will pay 5% more than they're currently paid. That will save the state of Alabama hundreds of millions of dollars. Secondly, the max rate is 10%. Hospitals will continue, as we have already, we'll continue to pay our share of that for the hospital cost. But beyond that, there are savings associated with expansion. People who right now we're paying 28% match on, we may be able to get, if we were to close the coverage gap, we may be able to pay for them at 10%. But as a doctor, my real issue comes down to this: patient outcomes are better in expansion states. Cancers are diagnosed earlier, specifically prostate and breast. People get interventions earlier. Diabetes is diagnosed earlier. It's just the right thing to do for patients. From a financial perspective, tax revenues will go up. If you bring in $2.2 billion of new money, you're going to see taxes go up. Now, most of them will go to the Education Trust Fund, and that's a positive. But taxes will go up. The other thing for individuals, in states that have expanded Medicaid, the FICO scores, your credit scores, also go up because there's less bankruptcy and less lingering debt associated with medical conditions. So I think we are, to quote Yogi Berra, we are at a crossroads. We're going to take one. I don't know which one we'll take, but the healthcare system that we have now we cannot continue the way we are now. We will lose too many hospitals in the intervening years. So it's our opportunity to make a difference. I will close with that, and I'll Glenn, give it back to y'all.
And this is, what do you think sets Coosa Valley Medical Center apart from other rural hospitals? Because what we heard, there's 2% of our hospitals are rural hospitals in the state of Alabama.
Well, Laura, first I would say, I'll point to Amy's slides, and say the fortunate circumstances led by our physicians and our clinical team, many of whom are here today, and the work that they do each day to ensure clinical outcomes are outstanding. We don't always get it right. We're not perfect, but the outcomes are very good comparatively. And I hope everyone understands that those slides were not to be boastful. They were not to be harmful to other facilities. But one of the things that I think smaller community hospitals have faced for years and years and years, and I've been in a number of them, is the notion that because hospitals are bigger and in bigger cities, they provide better care and derive better outcomes. Absolutely not the case. So we're very fortunate to derive great outcomes. And then finally, I would say the support of this community is very important to us. It's people that we see at church and school and at the local grocery store. Their support matters, and we want to do everything we can to meet and exceed their expectations.
And I think you should be boastful. Those are important numbers to share with the community, because things are not always as they appear from a broad perspective, and it's I think you should. You have a lot of data to be very proud of, and if you've ever been a patient, whether it's an outpatient or an extended stay, you know the quality of care that you get at CVMC. So I want you to continue to be boastful. It's part of what we do. We're very boastful about our healthcare provider when we're recruiting new business and industry and new residents. That is important to us, so continue to share it. This is an interesting perspective I was curious to learn about. We recently had our Ignite Business Summit, and we heard about the generations in the workplace. And currently, we have more generations represented in our workplace than ever before. Are you seeing differences in the way the generations approach healthcare, and how are you adapting to their preferred methods of treatment? Just for instance, and this was a result of COVID, but we're seeing a lot of healthcare utilize digital treatment and rather than face-to-face treatment. So how is that affecting your plans for diagnosis and treatment?
I'm going to ask Amy to answer this, but I'll tell you this sort of anecdotally and directly. I always encourage our team to call me Glenn. The 45 and 50-year-olds call me Mr. Sisk, and the 18-year-olds call me Glenn and give me fist bumps going down the hall. So things have certainly changed.
Yeah, Laura, the whole time you were talking, I was thinking about how about our team members, not even our patients, because Chrissy is an expert in this area and could talk about it the rest of the day, but we have a lot of conversations about our workforce. So obviously the patient piece of that is important, but guys, there are so many generational differences now in the workforce. And the issues are not really around us as an employer being responsive. Obviously, we are doing continuous training. And if you've ever been to a class that Christy teaches, I know many of our directors here have been, maybe you need to open it up to the community, but she has some really great classes that she does internally for us about how to work with generational differences. There's been all kinds of things. I'm thinking now about different color hair, that we've had to deal with, things that I never thought I would be okay with in the workplace. We've had to really be responsive and really get focused on looking at the quality of care that individuals contribute to and not being so focused on things that my generation in particular used to pay a lot of attention to. So it's always trying to find that balance with our workforce. On the patient side, we still operate today under the patient is always right. And that's not necessarily something that always feels good to us, but it's constantly challenging us with, hey, I looked up on Google, or hey, WebMD says this, and are you guys using this, and can I look at the medical record, and can the doctor explain to me why he chose this antibiotic? So we're constantly trying to work and adapt to those different generational needs because they exist not only in our patient population, but in our workforce as well.
Yeah, I mean, I agree. We take for granted that healthcare is healthcare because we all still have the same physical bodies of operating from an operation perspective. But it is something to consider, not just from your workforce, but from the treatment perspective as well. Dr. Williamson, I've got one more question that I'm going to open up to you all. I could sit and talk about this all day long, but how is the hospital, and you alluded to some of these, but how is the Hospital Association supporting specifically the rural hospitals in Alabama?
Well, I think, look, there are no hospitals that are more important in our system than the rural hospitals. And I learned that during COVID when we found ourselves with urban hospitals that we were trying to find ICU beds in, and there weren't any. And it turned out that what was happening often was rural hospitals were hanging on to patients that they could take care of. And by doing that, they were avoiding the overload of the urban hospitals so that they could continue to manage their patients. So that's why I get really concerned when people talk about the solution here is, well, we just need some rural urgent care centers or rural freestanding emergency departments, and we can just ship people to urban hospitals. That's fine, except when it isn't fine. When the system is overloaded, whether it's COVID or influenza, or whether you've got a mass casualty event that people need different levels of care, the rural hospital can take care maybe of some of the lesser acutely ill, and you transport the others to a more acute care setting. If you transfer all those patients, you're going to overwhelm the larger hospital. So the system has to focus, has to function with different levels of hospitals. Now, how do you protect the rural hospitals? Well, number one, I say that 100% of the money that funds hospitals comes from the hospitals. Actually, we were able to get $7 million from the legislature a couple of years ago, and thankfully they've continued that to specifically raise the Medicaid reimbursement rates for rural hospitals. That has been very helpful. We've also been working very hard. We've got about 4 hospitals that are on the verge of crisis that are now looking at a transformation to be a critical access hospital. Hopefully that's going to work. That will probably keep them in operation, maybe with less resources, less services than they would have had otherwise, but some services are better than no services. We've got another handful of hospitals we're working with that are looking at becoming rural emergency hospitals. Again, it's a last gasp to try to keep them open. So it's a combination of trying to provide them money, provide them resources, and provide them really, we also have a quality program that many of our rural hospitals participate that help give them this kind of data to allow them to compare. So, it's all, we've been fortunate in Alabama in that we have one hospital association. Other states have multiple hospital associations. Nothing is less effective than hospitals fight among themselves publicly when you're trying to accomplish something. We've been able to avoid that.
Thank you for your support of the rural hospitals. Any questions from you in the audience? I know this is a very inquisitive group, so. Yes, Russell.
So I'm sure this will be great for you, Amy, but have you had any trouble finding nurses, recruiting nurses, and what does the future of the nursing profession look like?
It's interesting, the Alabama Board of Nursing released a document this week kind of projecting the next 5 years in nursing. And the average age of a nurse has actually dropped about 4 years as of the report they issued this week. So you may remember it was up above 40, it was up above the mid-40s, which told us at that point in time we were getting ready to have a lot of people retire from a nursing perspective. And then when the pandemic hit, that in part was why we had so many issues with nursing shortages, is we had a lot of nurses retire. When I say we, I mean the hospital industry. Coosa Valley was no exception to that. We had nurses that were afraid of getting COVID. We had nurses that were afraid of getting COVID and taking it home to someone they were caring for at home, that were very close to retirement or had decided to work a year or two beyond where they thought they might retire. And when the pandemic hit, they left the workforce, and they left it in droves. So every hospital in our area, in Alabama, and in the nation right now is in the process of rebuilding a workforce. And that's where those workforce issues come in with generations, because we're not having them trickle in like attrition when you have one or two leave and you replace them and it's a slow process. We're acquiring new generations in droves as well. And so it's causing us to have to respond a little bit faster. But the report from the Board of Nursing this week, with the average age of a nurse in the workforce dropping now to, I think it was 41, Russell, don't quote me on that, but I think that was the new age, which was 7 or 8 years below where we had been. Was optimistic to me, and Dr. Williamson also mentioned earlier about a hospital-based school of nursing. We're getting ready in a couple of weeks to meet with CACC to talk about how to look at nurse training a little bit differently, because this shortage is causing us to have to look at a lot of different things, a lot of different avenues that we never thought we would be talking about. So does that answer your question?
We have, so what do you think is out here?
Well, Ms. Goodwine has been instrumental in Coosa Valley's healthcare workforce initiatives. She and I talked earlier this week, or maybe late last week, about some things, and I'm actually connecting her with the Board of Nursing. I asked her yesterday, can I get you connected to the Board of Nursing? The governor's healthcare workforce task force that ALAHA is helping sponsor, we met yesterday. And one of the questions in that task force meeting was, how can we fund dual enrollment for these students so that we can put LPN programs on high school campuses, so that those individuals who are interested in a nursing degree can graduate from high school as an LPN, and how can we get that funded? And this lady had already secured nearly $70,000 for our local high school to be able to support dual enrollment. Because dual enrollment's a great thing, but if all students can't access it, then it's not equally accessible to all students. And from a healthcare perspective, we need all students to be able to access it so we can produce LPNs in high school.
I think that's one of the successes, one of the many of CVMC, are the partnerships that are established, and the partnerships with our educational providers, K-12 and post-secondary. We're very fortunate to have CACC and 2 school systems that support our region that are very engaged with healthcare and the opportunities that exist there. Both are led by some amazing career tech directors. So those partnerships are key, and we just don't talk enough about those and put emphasis on those. Any other questions? Okay.
I know this was mentioned a little bit, but it just seems like there are a lot of hospitals that are being taken over by the larger hospitals. And so what do you see going forward as far as keeping it independent?
Yes, ma'am. Well, thank you for your question. I would say in 2004, when the authority said we want to move away from a 10 hospital system to become independent, that was bold, certainly very bold, and we believe in that. I think I can say that with confidence that the members of our board support it. I think the management team works very hard to ensure that that occurs, but it's not a guarantee. There is no way that we can ensure that occurs. I'll give you a couple of examples that mean a lot to us and why we want to be this way. When we were owned and operated by Baptist 2004 prior, one of the things we wanted to bring to Sylacauga was a sleep disorder center. Now, I don't know how many of you men out there snore, but I snore a lot, I'm told. And that's pretty basic medicine. Well, the answer from the Baptist health system at that time was, no, you can't do sleep studies in Sylacauga. You've got to send them to the big house in Birmingham. Well, that's the way things go in that model. So while there are some inherent advantages, as Dr. Williamson said, you can have some economies of scale in a system model, but not only could we not have a sleep disorder center, but I can assure you we would never have had a cardiac cath lab where you can have interventions done like you can in Sylacauga without having to go to UAB, Grandview, etc. So our hope is to remain that way. Obviously, clinically. We will continue to try to drive great outcomes. But at the end of the day, it's a financial decision. And as long as we can keep things moving favorably with traditional payers, and we can increase the support from non-traditional means of income, philanthropic giving, governmental support, et cetera, that will help us be able to accomplish that. And we hope to do so.
We hope so as well. Any other questions?